So thank you very much, those of you who are still here. I just had a word with my learned erstwhile friend over here who thinks some people might have thought there was a break. I'm sorry, there isn't. We're just powering through this session. So if there is an influx of people who just suddenly realise they didn't need the donut after all, we'll try and talk over them, shall we? It was really, actually, the next session was very, very nicely teed up, I thought, by Jeremy Hunt, who spoke about the Francis report for quite a large proportion of his speech. And that's really what we're here to discuss now this afternoon. How does one make the NHS safer? For a while, that cloud of mid-staffs hung low and dark over the whole service. We heard from Jeremy Hunt that it must never happen again, and he gave the indication that it will never happen again. But how do you ensure that? How do you ensure that when the things that are going wrong are sometimes going wrong such a long way away from the person who sits in the chief exec's office or in the head of hospital's office or whoever it is? These distances, how do you bridge them? What are the problems and what are the solutions? Let me introduce you to an excellent panel that we have to discuss this. We have Paul Scandrett, who's Director of Healthcare at Allocate Software. Helene Donnelly, who you already heard Jeremy Hunt refer to, who's Ambassador for Culture Change at Staffordshire and Stoke-on-Trent Partnership NHS Trust. And Dr. Patrick Cadigan, who is the Non-Executive Director of Heart of England NHS Foundation Trust. The way we're going to do this plenary is that we're going to give each one of these speakers 8 minutes to make their case, and then we'll have a little bit of a discussion and open questions to the floor. So if you could all please, first of all, welcome Paul Scandrett to the lectern. Paul.
Thank you. I would take my jacket off because apparently that's de rigueur when speaking, but it's a new suit, so I'm going to make the most of it. I've spent the last, I guess, 20 years looking at staffing issues in a lot of industries, the last 10 of which has been in the NHS. My wife, Alison, also happens to be Dr. Spencer, not Mrs. Scandrett, as she reminds me from time to time. And Alison said working in the NHS will be like nothing you've ever done before. And she was right. I've had the pleasure of working with some amazing people, and I now realise it's not only Alison who is still working at 2 o'clock in the morning. Over that time, I've learned quite a bit about staffing in the NHS, but actually my experience of the impact of getting staffing right for patients and their families was when I was a 10-year-old. The night before, my father was having surgery for a serious heart condition. As you might imagine, as a 10-year-old, I didn't fully understand what was going on, but I know what was going on definitely wasn't good news. We were worried. Myself, my brother, my mum, my father, being a stoic Welshman, showed no concern whatsoever. That night, the ward sister stayed with us for half an hour. That half an hour made the next 48 hours so much easier. Not easy, but easier. And to this day, I remember what she told me as a 10-year-old. She said, "You will have your dad back in 48 hours, and he will be like Steve Austin, the Bionic Man, stronger, faster, fitter than ever before." And indeed, he was. If I then wind the clock forward some 25 years, we'd just done a piece of staffing work for a trust, and we were presenting to the board. One unit in particular were incredibly short on staff numbers. When we presented those findings, the chief executive said, "That is the same unit, isn't it, where I've been with the commissioners this morning talking about how we're going to not only deliver what we're currently doing, but a broader range of services." He said, "I wasn't aware that we couldn't even deliver what we've got now." When I came out of that meeting, I then met the unit managers, and indeed one of them came up to me and said, "I'm the unit manager for Unit X." I said, "We've just been talking about your unit with your chief executive." As you might imagine, she was concerned and said, "What did you tell the board?" I said, "I told them the truth. I don't know how you're coping." She was close to tears and said, "I've been trying to tell people this for a long time. nobody understands. And it wasn't that they weren't listening, I think. It was more that they didn't have the data to understand exactly what that meant. So in those two examples, from a 10-year-old through to a chief exec, a unit manager, and indeed the patients themselves were all impacted by the lack of transparency around data. So the focus that is there today is incredibly important. But here's three practical things that we've absolutely got to get right to make the most of this opportunity. Number one is when we're looking at the staffing data, averaging is dangerous. If you look over any particular unit, over even a 7-day period, you will have numbers up and down. You might have too few staff at the weekends, too many midweek. If you average it, it's going to look like it was okay. If you do that over a month, you've got an even bigger opportunity to hide actually what was going on. Just doing it between early and late shifts can have a similar impact. So we have to think really carefully about the data and how we present it. Secondly, and it's probably the biggest opportunity, for those of you who work in acute inpatient areas, there is a massive amount of work going on at the moment to produce your staffing numbers, which are going to be published in the next week or so. So everybody is going to be reporting in a week's time what happened in May. I've got a simple question, though, to ask everyone today. How many people are reporting in June what July looks like? Because, of course, saying something bad happened in May in terms of staffing is exactly that. If we look forward, that is where the opportunity sits to change. And the way that rosters work, generally they put together 8 weeks before they go live. If you get it wrong at the start, the problems that you're faced with on Thursday, the 5th of May today, could have been created 8 weeks ago. So get the data right in terms of the understanding and look forward. The final point, I think, then to focus on is how the workforce can react. One really simple question. Why do we, as an organisation, have a nurse bank? Is it to deal with short-term absence? Is it to deal with vacancies that have been left over? Is it to deal with fluctuating patient demand? The reality is it's going to be all three of those. But the way in which you set up that workforce to react to the shortages is going to be absolutely key. My concern otherwise will be we'll start reporting that the numbers are down and not be able to react to it. So in summary, what is happening is absolutely right. Transparency is key, but the right sort of transparency, and the right sort of transparency ahead of time. Because we can positively impact patients, their families, just like this 10-year-old was impacted some time ago. Ward managers who are under pressure, and indeed chief executives who are looking to improve the level of service. So the data has to be right ahead of time and with a workforce that can react. We cannot let the opportunity that is now in front of us go away. It's a once-in-a-generation opportunity to change the way it works. I've got a 10-year-old and I've got 3 others as well. And if I've got one ambition in life, it's to make sure that collectively we get this right so it'll help them and their children too. Thank you.
So the next person to speak, Dr. Patrick Cadigan, who's Non-Executive Director at the Heart of England NHS Foundation.
Thank you, Anita. And it's important that I confess that as well as being a non-executive director, I'm a practicing cardiologist at Sandwell and West Birmingham Hospital, so that you understand my prejudices. When Robert Francis was preparing to write his report, he held a series of seminars. One of these seminars was on regulation, and I attended this seminar, and we heard a talk from Her Majesty's Inspector of Prisons. And the Inspector of Prisons told us that there were really 2 varieties of prison. There was the virtual prison, which was the prison the governor thought he was running, and there was the real prison, as experienced by the staff and the inmates. And sometimes, as a new non-executive director, I feel anxious that the story I'm hearing at the Trust Board is about the virtual hospital and not the real hospital. Is there any evidence that fuels that anxiety? Well, I think there is. And the recent King's Fund report on their survey of culture and leadership in the NHS was very worrying. It showed a consistent divergence between the views of the executives and the staff when asked questions about the organisation. So, for example, when asked the question, is your organisation characterised by honesty, transparency and challenge, 81% of executive directors said yes, it is. Only 31% of nurses agreed with them. So there is a disconnect between the board and the staff that worries me as a non-executive. I have other anxieties, of course, the anxiety that the buck stops with the board. And Robert Francis made this absolutely clear. You don't have to read the full report to get this. You don't have to even read the executive summary. What you can read is his introductory letter to the Secretary of State, where in his first paragraph he says, this was a serious failure of a provider board who did not listen to their staff and their patients. So how is a trust board, and how particular is a non-executive director, to discharge this responsibility regarding patient safety and to deal with this disconnect? Well, there's quite clearly enough data for the trust board to work on. Our bulky trust board papers glow with colour, red, amber and yellow. There are more thermometers and dashboards than one can shake a stick at. There is information about mortality derived from increasingly arcane formula on infection rates, etc., etc. I could go on. And the challenge for the board and the non-executives is to make sense of all this data and decide which data is significant. Now, I think what we need to do, and what many trusts have started to do, is make much more use of soft intelligence to back up this data and triangulate it. And if we take one example, the number of staff on a ward, how is a board to make sense of that raw data without having backup data on the effect of quality of care derived from a number of sources, and particularly soft intelligence from patients and staff? And I'm particularly interested in staff who are peripatetic, who move between wards. Junior doctors are a good example, therapists. They're in a strong position to compare and contrast. What about the role of non-executive directors in this? Well, the role of a non-executive is clear. It's to challenge the board. And in terms of quality data, it's to make sure that the integrity of that data is sound. Monitor's quality framework makes it quite clear that directors should have the skills and knowledge to do this. So it was surprising to me to discover in a recent survey of the occupation of non-executive directors that only 8% have any frontline NHS experience. The majority of non-executives come from a legal, commercial, financial background. As a medical non-exec, when the trust has a financial issue, I go to my accountant non-exec colleague to help me understand that issue and to formulate a challenging response. How can a non-executive group without a clinician understand the complex clinical data we produce and formulate a challenging response to the trust? So I'm sure that all trust boards should have a non-executive with frontline NHS experience. The real test of the board, of course, is not the data, but the action it takes. And I think we've learnt that hard regulation doesn't work. Just telling people what to do doesn't work. We need to help people to do things for themselves. And there have been a number of publications, really, which point the way for us here. So the King's Fund, in response to its survey showing this disconnect, has suggested a program of collective leadership. The Royal College of Physicians did much the same in its Future Hospital report published last year when it talked about citizenship in an organisation. The concept that everyone in the organisation feels a responsibility towards the success of that organisation and the quality of care. Now, this is an action for the board to take in instilling a new culture, and Don Berwick has given us some clues about how we might do that, and that's by giving people quality improvement tools. We should teach this science from the earliest days of training as a medical profession, so that when the moment comes to whistleblow, one doesn't whistleblow to the chief executive, God forbid, the Daily Mail. One whistleblows to oneself and asks the question, what is the problem with my service? How am I going to put this right? I now have the tools to understand quality improvement and how I can act. So what's my prescription for successful trust boards in this area? Well, firstly, being a doctor, of course, my answer to all problems is that there should be more of my sort of doctor. We need more GPs, we need more cardiologists. Actually, I'm sure we should have more frontline clinical staff acting as non-executive directors. And they will help the trust board with the next task, which is to understand, to filter, to prioritize the volume of patient safety data. But the final task is to make sure all our staff go with us, away from a culture that is mere compliance and towards a culture of continuous quality improvement. Thank you.
Thanks very much. And our final speaker, and then we will be opening it up to you. We'll chat amongst ourselves for a little while, but then you're very welcome to ask questions. Helene Donnelly. Helene.
Thank you, it's a privilege and a pleasure to be here to speak to you today. I'm sure many of you are already aware of a little bit of my background, but I don't think it ever hurts to touch upon it again because it's such an important issue, and it's obviously how we came to the Francis report in the first place. And that was the things and the examples of the things I was seeing as a staff nurse in the A&E department at mid-staffs. These were pressures that were in the main due to resource issues. There were not enough nurses, not enough doctors, not enough equipment. But it was also a mindset and a cultural issue which was quite historic, and I'm sure isn't and wasn't just limited to Stafford Hospital. I'm sure it's echoed throughout the NHS. The effect of that was, as I'm sure you're all aware, that patients were suffering, patients were being neglected, patients were being left in soiled sheets because the nurses were being pulled away to do other things rather than change them. Important treatments were not given, medication was not given. And a lot of this, obviously, in the A&E department was fueled by the 4-hour breach time. And so methods to manipulate that and massage the figures were adopted. The virtual clinical decision unit and the actual clinical decision unit, which was a room that patients were literally dumped in without access to food, water, natural light, correct and adequate toileting facilities, and they didn't even have access to call buzzers and that sort of thing. Throughout all of this, as initially quite a junior nurse, I could see that this wasn't right. I could see that if this was my father, mother, grandfather, grandmother in those beds receiving that kind of level of care, that I would want somebody to do something about it. I would want somebody to stand up and say, hang on a minute, the King's wearing no clothes here, something's not right. What can we do to make it better? So that is essentially what I tried to do. And I tried to highlight the fact that we didn't have the resources, we didn't have enough nurses, we didn't have enough doctors, in the hope that that would then be addressed and amended and things would get better. But instead, I was bullied and threatened, and so were other people who supported what I was saying. So that, for me, has highlighted the need to help support, particularly frontline staff, but all NHS staff, to raise concerns in the interests of patients when they see them. I think also the crucial thing is that I could see that there were problems way before they got to a sort of crisis point. And other than writing clinical incident reports, which I did in their hundreds, I felt impotent to do anything else. And then when I did try and raise things more formally, I was obviously bullied and threatened, and things were covered up. So where did I go? Who did I speak to? And I absolutely felt alone. So in my new role as Ambassador for Cultural Change with Staffordshire and Stoke-on-Trent Partnership Trust, that is exactly what we're focusing on. We're focusing on giving the frontline staff a voice. I work completely autonomously. I can go anywhere and speak to anyone, and I report directly to the Chief Executive. And that alone really gives staff confidence. There are many other routes and methods used in our trust and in many other trusts which do work and sometimes don't. So it's not a replacement of their existing routes, such as HR, professional leads, unions, and obviously line management. But it's an additional approach, and it's a sort of safety net to try and capture things, and also try and encourage staff to come forward. It's about training staff so they know their duty in raising concerns, but also giving them the tools and the knowledge so that they can go ahead and do that if they need to. The other main element for me, though, is that it's about prevention rather than cure, and it's about being proactive rather than reactive. As was touched on earlier, I think it's really important that we try and prevent people getting to the point of having to whistleblow or raise a concern formally, because if you've got to that point, then there's obviously a problem, there's potentially a failure, or potentially harm has already been done. It's much more important to listen to the staff from the outset. The staff are there, frontline staff particularly, 24/7. They see what works, what doesn't work. They need to be consulted and encouraged and listened to. They need to have their ideas and initiatives taken forward, because that will help problems, or solve problems, and it will prevent things from getting worse and getting to the point of somebody had to have to blow the whistle. So this is what we're trying to encourage now, and my Chief Executive, Stuart Point, is here today. He's really keen to share this, share what we're doing, and help anybody else if they'd like to learn more about this, because it's something we can see working in other trusts all through the NHS, and something that we consider to be quite vital. The more we're doing this, the more we're seeing from frontline staff within our own organisation, but in others up and down the UK. We're both contacted quite frequently by nurses, doctors, healthcare professionals all throughout the NHS, social care workers as well, and allied health professionals who are worried and concerned, have tried to raise issues through normal conventional routes, but are feeling that nothing's happening, no action's being taken, so they want support and advice on where to go to next. So we believe that if there was an ambassador for cultural change within every organisation, which could then create a network to help promote best practice, help prevent problems in the first place, but obviously if there are issues, give those staff a voice to the top board level and to help action be taken, then that's the most important thing. And that's what we'd like to share. And I think the crucial issue really is that, as the Secretary's touched on, it's about the NHS staff. We won't have an NHS if we don't listen to the staff, and patients will suffer as a result. So that's the priority, and we will never achieve cultural change if we don't listen to staff. But you have to empower them. Policies and procedures are not enough. Lots of people tell me that they've got a great HR whistleblowing policy, so they're okay. I don't believe that. And even if you are, having this approach won't do any harm, but it may do a lot of good. Thank you.
So once again, if you'd like to ask a question, please put your hand up very clearly, and somebody with a paddle will bring a microphone to you. Helene, can I just start with you? I interviewed somebody after the mid-staff's stuff had died down somewhat in the press. So it was a period of calm, if you like, and it was a patient whose mother had died, who said there was still, you talked about bullying and hardship within the culture. This is a civilian, if you like, who was forced to move from the area. You know who I'm talking about. Her mother's gravestone was actually vandalised, and she was forced to leave her home or her property, and she lived for a while, I don't know where she is now, but in a caravan, because she just said she was frightened to live with the neighbours that she had thought cared a damn about what had happened in her family life. First of all, how do you unpick a culture which seems so, well, perverse, if you like, that the people who are trying to shine a light on wrongdoing are the ones who are getting their heads kicked in over it?
I think, well, once it obviously gets to that stage, there's been many failures and problems along the way. So it's about trying to unravel that and getting back to the key issue, which again is about listening to staff, empowering staff, and also making those who are responsible accountable in some instances. And at mid-staffs, the vast majority of staff working there were hard-working, caring, dedicated people who were absolutely on their knees under the pressure and trying to do the best under those circumstances. But it is important to acknowledge that there were a few both in management positions and in clinical roles, who just did not care. They didn't want to listen, they didn't want to know. And those people have to be made accountable and to some extent made an example of. That will eventually, although it takes a huge amount of time obviously, filter through within that organisation and others, that those behaviours are not acceptable, will not be tolerated, and ultimately that will bring up the culture that we need. But it's going to take time.
Have sufficient heads rolled yet, or do you need quite a few more to roll?
I think potentially yes, there are still more to roll, and I think with initiatives such as the duty of candour and vicarious liability and things like that, there is becoming, there is more of an onus now on looking at that kind of accountability. But I think certainly again for sort of frontline staff, the pressure and the fear of speaking out in the first place doesn't even kind of take that into account. For many people, it is how they're going to be viewed amongst their peers, by their colleagues, in the local communities as well, particularly in small district general hospitals where people live and work alongside each other, and the impact on their families. Do their children go to the same school? Do they know people in the local community? It's that makes people frightened, not necessarily a career-limiting fear, although that applies as well.
Which actually, and I know we've got one question here. Have we got any on that side? You've got one over there? Brilliant. We're going to come to both of you in just a second. But that brings me, I was really interested in your idea of soft intel, and that perhaps the best people to provide that soft intel would be those who are peripatetic. I think that's what you use the phrase, junior doctors who come and go, physios who come and go. If it's so hard to do it when it's your daily existence, why on earth is a junior doctor who's going to be out of there in a year going to bother putting their head above the parapet when it has historically and still is quite dangerous to do that?
Well, people don't necessarily need to put their heads above the parapet, because there are surveys done by the GMC and surveys done by the local trust which are anonymised, and one gets quite a lot of data from those collective opinions. And indeed, it's much safer to whistleblow as a collective than as an individual, and it's much more powerful if every doctor in a hospital is saying that Ward 3 is unsafe. It's probably true. Individuals can have other motives and reasons for doing that. No, the idea of using trainees was picked up by Robert Francis, who said they were the eyes and ears of the system. And there's an interesting program going on called Learning to Make a Difference, where we're giving junior doctors quality improvement tools, mentors, a web-based approach, and telling them, during your placement in the cardiology firm, see what you think is going wrong. We will give you the tools to try and put it right, and teaching people that they are not helpless, that they can actually do things themselves.
Right. I would love to ask you a question, but I'm going to open it up now. Yes, very patiently there with the microphone.
Thank you. Jonathan Inglesfield. I'm a GP and I'm Medical Director of Guildford and Waverley.
Can someone do something about the sound? Because it's very, very woolly up here. You're speaking very beautifully clearly, but we have a problem.
Thank you for the presentations, which were great. I'm Jonathan Inglesfield. I'm a GP and I'm Medical Director of Guildford and Waverley CCG. And my question is really to Dr. Cadigan. And you mentioned one of the issues around trust boards being clinician poor when it comes to assuring quality. And I just observed that we now have clinical commission groups which are incredibly clinician-rich opportunities. Are we missing an opportunity for trust boards to work closer with CCG governing bodies in assuring trust quality?
We may be missing opportunities. I think a little depends on your local circumstances and how many clinical commissioning groups you're working with, and whether we can align the quality agenda with them. But I agree entirely that's a resource that we shouldn't miss.
Question up there near number 1.
Karen Middleton, Chief Executive of the Chartered Society of Physiotherapy. I want to build on that last question, actually. Given we know that the diversity of boards will enhance the quality of care, what does the panel think about ensuring that clinical director posts are opened up to a more variety of clinicians beyond doctors and nurses? Aren't we just missing a blatantly obvious trick?
Well, Paul, you touched on boards in your submission. Would you like to take that first?
Yeah, look, from my personal perspective and experience, I was once asked who should lead one of our projects. Should it be the nursing director? Should it be the ops director? And to which my response was, it's whoever is the best person. And I think too often people are pigeonholed into this is the person who does this role, and they might be absolutely the wrong person to do it, whereas one of their colleagues could be absolutely the right person to do it. So for my own personal experience then, it's the right person in the right place at the right time for whatever that role might be.
Okay. Do either of you want to take that up? Otherwise we can take another question. We've got one over here. Yes. Gentleman here.
Thank you. Chris Buckler, Chief Executive of Leeds and York Partnership NHS Foundation Trust. Brief comment, if I may. Certainly in mental health and learning disability services, we put a lot of time and energy and effort into supporting networks and groups of service users and carers to actually be in a constant engagement with us related to what we're doing and how we're doing it and where we need to improve. Within our own wards, we also employ peer support workers. So these are people with experience of mental health problems working alongside clinical teams who act as an additional bridge between the professionals and service users on the ward. So I would just invite people to think slightly more widely about where you can get those inputs from.
Can I throw it back to you?
Sure.
Just the constant engagement that you have. What form and shape does that take? And then we'll see whether our panel thinks that might work on a broad hospital scale.
Yeah, it works in a number of ways. So, for example, we have regular service user networks by which senior leaders of the trust and people in management positions actually engage with service user networks, to actually have honest conversations about what's happening.
So this is a face-to-face conversation?
It is very much a face-to-face conversation.
Right.
And similarly, we also have a carers network within our organisation. And myself and other people within the organisation actually make ourselves available to actually listen directly to the views and inputs of service users and carers. And we also have the routine things which other boards have, for example, patient stories to the board.
Right.
But I just think you just have to think quite laterally and widely about how you access those inputs.
Well, can I ask Patrick, is that something scalable, do you think?
I think it is, and certainly in some trusts, patient user groups, often grouped around particular illnesses, are developing. And of course, you have a group of patients with a particular illness focus, and I think that's a way that's certainly being tried and one we should develop.
Helene, do you want to take that? We've got a question here about, I think it's our friend from Moorfields again would like to ask a question. Helene, did you want to come back on that? I think what sometimes, and you class myself as one of these people who do not work within the health service, but it is the scale of how many people are working, how many people are going through, the retention of staff, for example. Some areas have an enormous turnover, which in itself you're not going to be able to fix overnight. So how do you even start? Where do you start? What's the biggest priority to try and actually stem the flow of problems that could exist?
I think, you're absolutely right. Clearly, cultural change is going to take decades probably, but it's about getting staff engagement, and there are many ways to do that, and lots of places are adopting similar, and within our trust we have similar things going on as well, and all that can come collectively together and give a really good picture about what's going on in the organisation. So again, certainly my ambassador for cultural change is just another route for that. And I think, but it can offer soft intelligence as well as really hard facts and really hard issues that we can then follow through. But I think it helps to have somebody who they can come to for advice and signposting, and sometimes a bit of hand-holding as well, because that's what's needed.
Can I just ask, before we come to your question, yours will be the final question of the session. Winterbourne View taught us something, that you put a simple camera next to a bed and you'll find out more than any soft intel can tell you. How do you all feel about installing more cameras in hospitals, in wards, and particularly in vulnerable units where people can't necessarily articulate what has gone on with them? Can I start with you, Paul, on that?
Yeah, well, look, the first thing I want to come back on a point you made about the scale of the NHS. And quite often the NHS is described as a whale, which is really hard to make a turn direction. Actually, it's not a whale at all, of course. It's a shoal of fish that looks like a whale. And every now and again, those fish go in completely different directions. Having never thought about the question on are cameras going to help, I'm not sure that I'm the best person even to be beginning to think about answering that question.
You don't have to. I mean,
what I would say is this: that since we put a camera next door to my 13-year-old's laptop. His use of that laptop is very different. He knows he's being watched.
Okay. So that, I mean, that sounds, just even from a personal perspective, it's not the worst idea in the world. What would you say, Patrick?
I think in the generality of things there would be issues of privacy and dignity which might be difficult to overcome. There are pretty good records of care delivered or not delivered available in other ways, and I think it might have an inhibitory effect on the clinician-patient relationship which would outweigh the benefits.
Okay, Helene, what do you think?
I'm pretty 50-50, which I know isn't helpful, but I absolutely agree with that. I think there's massive issues about the privacy and dignity aspect of it. But I think in certain places, I think potentially more so in care homes than in hospitals, where there are less people who are going to be in there and monitoring, watching, I think it may have to be implemented, because they are so vulnerable and they don't have anybody to speak out for them, and there are less professionals in and out who would be able to necessarily pick up issues.
Thank you very much. It's just something I always wanted to know, whether it would be well received or not. Final question. Is it on?
No?
Yes, it is. There we are.
Thank you so much. I would probably I have two questions, one for Helene and one for Patrick. But before I do, just a comment about the cameras.
Yeah.
What Helene is seeking to do is cultural change. Probably in the transition, I would say cameras may help. But if we're going towards culture and value-based interviewing, you get the right people. John Lewis interview and select people on a set of values. If you don't fit, your face doesn't fit. And if you do, you do. In this transition, it may be helpful, but I would love to have a situation where you know what your 13-year-old is not going to look at without cameras, because they understand. So just a question for Helene. We have, yes, okay, maybe you take the utopia, but you start somewhere and you work towards
You're being heckled by the person sitting next to you. That's hilarious. Anyway, yeah.
She has teenage children.
Okay, fine.
They're my nephews. Right. So I trust them. She's not so much.
Okay.
I have a question for Helene around distributed care. Moorfields is one hub site and 20-plus sites. How do we keep that level across all of our sites, where some people may feel somewhat disconnected from the execs who probably aren't walking the patch or don't have an ambassador for cultural change? That's my question to you. And then my challenge as a Ned to Patrick. I was really concerned when he said on financial issues he would look to his Ned colleague with the recent and relevant financial experience. I'm the audit chair and I'm a chartered accountant. I do not want to be the only person asking the questions about the financial report. We have a joint liability. Any more than I would just sit back and expect the clinician specialist. I have a duty to understand those issues, because that's the role of the board. So that was just a challenge back about using a specialist.
Fine. Well, we'll do the challenge second, but let's go to Helene first, because that was the first question.
Yeah, I absolutely agree with you, the potential problems, but it works very well, and I can say so because the trust I'm now working for is a community trust, integrated, so we have health and social care, have 5 community hospitals, many other locations throughout a massive geographical area. So it's a challenge to get round, and you're quite right, some of them do feel quite isolated, but that is actually where the roles come into its own, because I personally go out, walk the wards, go to units, departments, centres, go and speak to staff and introduce myself. But also we've advertised the role quite dramatically. Everybody's probably getting quite sick of my face now, but they know that they can contact me, so that they can pull me in if they need it, completely anonymously. I don't take it any further unless I have their permission. But that's a really good way of helping them get somebody come to them and to listen to what their concerns are and worries are.
Thank you very much. And do you want to take the challenge?
Okay, well, I think the answer to the challenge is that the depth of my financial ignorance is something I have to confess. I obviously do need to understand these matters, and to understand them I need a teacher, and the most convenient teacher who understands both the issue and its relation to the trust is my fellow non-executive director.
Thank you all very much. We had the red light flashing. The red light was flashing for some time, and it's actually given up the ghost because it can't bear to tell me anymore that we should end. Thank you all very much indeed. It's been another very constructive day. Please join me in thanking our panel for this afternoon, and we'll see you tomorrow.
Thank you.
Thank you so much. Thank you all. Thanks a lot.